Hello, everybody. Hope that you're doing well. As opposed to sharing a screen and going over questions, we just thought to kind of do some rapid fire things that might be of benefit. As we've gone through our review course with my seniors that'll be getting ready to take their board exam, there's some good things to just kind of make sure that we're mentioning to kind of put in your mind to refresh just a little bit. So as far as equipment stuff is concerned, we know that typically the flow meters that we utilize are a Thorpe tube flow meter. We know that those can be pressure compensated or pressure uncompensated. With the uh, looking for or that it's desired to utilize a pressure compensated Thorpe tube flow meter. If you're going on a transport, the board on gauge may be quite a bit more beneficial for that because if you're utilizing the Thorpe tube, the metal ball, and there's going to, not be accurate with the reading, especially if it goes sideways or upside down, because that gravity will take hold of that ball and move there. We'll also look at blood tests. So, you might look at a CBC, looking at your complete blood cell count, looking at your erythrocytes, your leukocytes. You may look at the white blood cell count with the differential as well. So I would take a moment to kind of review those neutrophils, eosinophils, basophils, lymphocytes, the monocytes, things along those lines, so that you know if they're in reference to bacterial infection, viral infection, or what have you. Also look if a patient might be polycythemic, the conditions that may lead to polycythemia, whether those individuals may live at a higher altitude or if they have pulmonary disease. Pulmonary disease may cause their body to crank out uh, more erythropoietin to establish the creation or the development of more red blood cells to increase the overall oxygen carrying capacity for the blood. When you look at nitric oxide administration, we know that the inhaled nitric oxide administration can be given for the treatment of a patient that may have pulmonary hypertension or increase in pulmonary vascular resistance because inhaled nitric oxide therapy is a potent pulmonary vasodilator. So we also know that in doing so, one of the things that we need to check on a daily basis, in addition to our arterial blood gas that we're getting, we need to send that blood for co-oximetry, or you may see it referred to as hemoximetry. Why are we doing this? We're assessing for the formation of those methemoglobins. Remember, you can have abnormal hemoglobins, and in the presence of the delivery of inhaled nitric oxide therapy, the formation of methemoglobins or methemoglobinemia can be one of the byproducts. And remember, if you recall from the reading, when you draw an arterial blood gas, if you got a bright red color to that, typically it's pretty indicative that you've probably have indeed drawn arterial blood. Uh, if it's a little bit of a darker red color, you've probably potentially drawn venous blood or at least the blood super deoxygenated at that point. But if the blood is super dark or has like a chocolate brown color to it, if you remember from the reading, there's a decent chance that individual's got methemoglobinemia. And if you'll remember, the treatment for that is the administration of a substance called methylene blue. That'll be something that might be of a benefit to you all moving forward. Talking about those abnormal hemoglobins. We got the deoxyhemoglobin, oxyhemoglobin. That's a normal one. Fetal hemoglobins, methemoglobin, carboxyhemoglobin. Remember, you check a hemoximetry or co-oximetry if you got a patient that's pulled from a burning building. So if they got soot around their nose or what have you, we should also realize that pulse oximetry, just basic SpO2, is not going to be as reliable for those individuals because pulse oximetry can only detect that something is bound to the hemoglobin and not what is bound to the hemoglobin. If you'll remember, carbon monoxide binds with hemoglobin roughly about 210 to 250 times greater than that of that oxygen does. So make sure that you keep that in mind. You may have some neonatal pediatric questions in reference to assessing the readiness for birth. If they're after them, you can probably guess upon an APGAR score. So make sure that you can review your APGAR scoring as well, but also the lecithin to sphingomyelin ratio or the LS ratio. Which is 2 to 1, and typically that should indicate that the baby's lungs are providing enough mature surfactant to hopefully allow that baby to be able to sustain extrauterine life with the pulmonary surfactant doing what it's supposed to do and reducing the surface tension and allowing making it easier for spontaneous ventilation to occur. When you go over your terms, I would encourage you to review and study as many terms as possible, especially if something has more than one meaning. So, for instance, you've probably heard in clinic BiPAP referred to as such. The non-invasive means of ventilation with a mask. Uh, but BiPAP is a proprietary name, so you may look for non-invasive ventilation or non-invasive positive pressure ventilations, which could be for short NIV, NIPV, or NIPPV, depending upon how you would see that. We also have talked about in class that, we talk about look at the physiologic monitor or the cardiac monitor. But if you'll remember in the reading that we've gone over, physiologic monitors or cardiac monitors are also referred to as oscilloscope. So if you see the term oscilloscope, it's possible, or it's possible you may not recognize that or remember that because we refer to things as the monitor as such. But if you do see oscilloscope, we are looking at a term that could essentially mean that we have a cardiac monitor when we're looking at that as well. So a couple other things, and not to be terribly long-winded because I wanted this to be relatively short anyway, but we do know also that if you are looking at anything that deals with like a elevated D dimer, or you've got a patient that's in a motor vehicle accident and they are have like a long bone fracture, you're probably looking at some answer choice to deal with that of a pulmonary embolism. Looking at the neonatal side, you may transilluminate a chest for a pneumothorax. We also know that when we go back over our inspection, palpation, percussion, and auscultation, that we have disease or pathology that will push the trachea away from the affected side. We have disease that will pull the trachea to the affected side. So those are definitely things that we want to make sure that we can remember as well. um, Looking at the not pulse ox, but heliox concentration. So you've got an 80-20 mixture, 70-30 mixture, a 60-40 mixture. You may be tasked with calculating the total flow from that system. So if your flow meter is set at 10 liters, you need to remember the cylinder factors for not the cylinder factor, but the flow factor for those. So at 80-20, if your flow meter is set at 10 liters per minute, the factor for that is to multiply about 10 liters by 1.8. So the overall flow is going to be 18. And we'll just leave it at 10 for 60-30, 80-20, 70-30, and 60-40 as well. So you start out at 1 point, you drop down to 1.6 and 1.4. So if you had a 70-30 mixture, 1.6 is going to be the number used, so the total flow would be 16. If you drop down to 70-30, 1.4, still running the flow meter at 10 liters, you utilize 1.4, multiply that. The answer is 14 liters. What the total flow through that system would be. Your air to oxygen entrainment ratios, I would remember those common ones. Uh, you've got 30%, 40%, 60%, know the ratios associated with that and how to calculate your total flow. If need be, you can go back to the magic box if needed to help figure out some of that or employ that terminology there as well. Um, when looking at your ventilator graphics, make sure that you can recognize your flow waveform. If it's not returning to baseline before the next breath begins, it's indicative that you're likely have auto peep or air trapping associated with that. The different types of humidifiers that we talk about, whether active humidifiers, passive fires, and so forth. Um, so that's just a quick rundown on some of the things that we want to make sure that we are attentive to. Typically, if you're looking at the calibration of certain equipment, ABG analyzers and so forth, you want to be within two standard deviations. If you're going to calibrate your PFT equipment, you've got to utilize the large 3-liter syringe for those as well. So I'll try to do another rundown of some tidbits of information that may be helpful. But these are a lot of the things that we've talked about over the last couple of years, and hopefully you'll find them helpful as you're studying and preparing for your upcoming exams or your attempt at those exams. I wish you all well, and I'll do another recording for some rapid fire things well, but I'll also get back to just putting up a question. Uh, to help assist with that as well. Thank you all for your time and attention. I hope you have a good day.